Good evening, everyone, and welcome to Global IMMUNOTALKS. Thank you. Hello, everyone, and my name is Asia Rolls. I'm one of the hosts of Global IMMUNOTALKS. It's great to see you all today. This Global IMMUNOTALKS has been running for several years now. It was an amazing international initiative by Carla Rotlin and Elena Zuniga. And it's been a pleasure hosting over the years many amazing scientists. And today we are very happy to host Jolanda Vries. Hello, Jolanda. Thanks
Hello.
for joining us today.
Yes, welcome. Thank you.
So first, let me introduce you briefly, and then I think our audience already knows the drill. I'm going to ask you a surprise question. So Yolanda's research is mainly focused on dendritic cells, cancer immunotherapy, and imaging immune responses. She's chair of medical biosciences. She was the former president of Dutch Society in Immunology, and now the president-elect of European Society of Molecular Imaging. Congratulations.
Thank you.
Much more job, much more work to do. And she was one of the pioneers. It's really kind of a field that I think transformed a lot of immunology in translating dendritic cells biology into actual potential clinical implications. The first clinical phase 1 and 2 studies which patients were vaccinated with dendritic cells, which were loaded with tumor-specific peptides, which was initiated in 1997. It was, I think, a shift in the whole field. She also developed novel immunomonitoring assays that are highly predictive of the expected survival after vaccinations with disease. She also received many competitive grants and awards which recognize these amazing achievements. And we are very lucky to have her today with us. So let me ask you a question. What unexpected skill or experiences that are outside of science have shaped the way your career evolved?
Yeah, I think becoming a mother, having kids, um, that helps a lot in the lab. They do unexpected things happen. They are never on time, so you're always late for everything. Yeah, I think that's also learned me a lot to be more efficient, um, due to the kids as well. So I think being a mother helped also me as being a leader of a department, a chair of a department. Every now and then we are a bit childish. So uh, I think I learned a lot from having kids. Yeah.
And dealing with unexpected situations, right?
Yes. You have to deal with a lot of unexpected situations. Yeah.
It's wonderful. And I think science is like that, right? It's like the joy that comes from the unexpected things that come around. So
Indeed.
thank
Indeed.
Thank you very much for joining us today. I will please share your screen. And as you know, in the end, it's going to be abrupt ending. We don't have questions, so don't. It's a little bit weird to finish it kind of without a closure in the end. But we continue that all in the Twitter, and it usually goes very well. So please.
Yeah. Okay. Thank you for this nice invitation and the nice introductions. So my name is Jolanda Vries. I'm heading the Department of Medical Biosciences in Nijmegen in the Netherlands. And I will talk about dendritic cells in cancer patients. And the tumors, of course. The tumor and its microenvironment. There are many tumor cells, but what we all know is that there are also many immune cells all playing a role in this tumor microenvironment and the interaction between tumor cells and immune cells. If we look at all the immune cells, are very, very different ones. And if we want to harness the immune system to fight the tumor cells. So, of course, the immune system can be harnessed against the viruses, the parasites, and the bacteria. And here we know that key players are dendritic cells and T cells, at least in my point of view. We are doing it is a bit limited. There are, of course, many other cells playing a role. But in the microenvironment, there are many immature dendritic cells that takes up antigen. They migrate to the lymph nodes and mature on their way to the lymph nodes. They there interact with antigen-specific T cells. There's a recognition of the antigen and the MHC and the co-stimulatory molecules. We get activation of antigen-specific T cells, in my case CD8 T cells, because I load them with peptides, only recognized by CD8 T cells. And you get an army of antigen-specific T cells that can move to the tumor microenvironment and then delete the tumor cells very specifically. So, tumor and its microenvironment, the tumor cells, the immune cells, and dendritic cells are there, and there are, of course, also a lot of secreted factors. And the secreted factors by tumor cells are inhibiting the function of dendritic cells. So what we do is that we take dendritic cell vaccines. So we take cells from the patient, him or herself. We make them into immature dendritic cells. We load them with tumor lysates, apoptotic or necrotic cells, or RNA or peptides. Then we mature them with maturation factors. We do them into a syringe, and then we can inject them into the patient. And the goal is, of course, to get these antigen-specific T cells that then get rid of the tumors. Now, during the years, we did many of these investigations in patients, and here you can see an example that DC vaccination can be successful. So we have here on the left side in the red circle a tumor. It's a metastasis from a melanoma patient. So it are a melanoma tumor in the lungs. And before you can see clearly, there were not that many antigen-specific T cells. So not anti-tumor T cells. After vaccination, it disappeared, the tumor in the lungs. And what we also observed was that there were many antigen-specific T cells, many anti-tumor-specific T cells afterwards in the blood and in the DTH sites. So from this, we can conclude that dendritic cell vaccination can be successful against cancer. But unfortunately, it's not true for all patients yet. So what is the status? We have many culture protocols during the days. But we know that DC vaccination is very well tolerated and safe. It's effective, like the patient I showed before, in a minority of patients, but then it's really effective. So once you get the immune system started, you can often see that it's a complete response. We also know that DC maturation is crucial. So if you use immature dendritic cells or less mature dendritic cells, it's not working that well. And what we also know that if we can have these specific T cells, so the specific T cells against the tumor, patients who mount a response do much better clinically than patients who do not have these T cells. So there is a huge increase in the clinical benefit if specific T cells are present. What we also know is that if patients have a lower tumor burden, it's easier to induce these antigen-specific T cells. Of course, the tumor produces many factors that suppresses dendritic cell function or the immune system in general. And this is really true if we have patients with specific T cells, then it's often stage 3 melanoma patients, so not less advanced patients. What we learned as well during the years is that presentation of multiple epitopes, MHC class 1 and 2, is also beneficial for the clinical outcome. So if you have only one epitope, it's less efficient than if you have more, and it's even better to also include CD4 T cell responses. Another factor we know that is that the migration, if you inject dendritic cells, and here it's shown in indium labeled, so radioactively labeled cells, dendritic cells injected intradermally, then you can see they migrate to the next lymph node up here, but it's only a few percentage. It never exceeded the 4%. So there's a low, very inefficient system, and that's why we might inject them directly into the lymph nodes. So we have many things what we could do. So we can make variety in the dose, the activation, the frequency, the route of administration, so intradermal or directly into the nodes, the maturation, antigen targeting in vivo. We have to do very clear quality controls because if we have tolerogenic disease, they might hint to a more tolerogenic response, but we want for cancer immunostimulatory dendritic cells. So we studied now human dendritic cell subsets, and that are data I'm going to show you. I keep it simple because these are not all subsets that we know of. So we have the subsets depicted on the lower part. We used in the past always monocyte-derived DCs, but nowadays we are also able to isolate DC subsets like the DC1s, the CDC2s, DC3, and the PDCs. And we can isolate them for clinical use, which means that we are able to have products that you can use for in vivo application in humans. And this is really a crucial factor to implement novel subsets into the clinic. So I start with showing you some data on the plasmacytoid dendritic cells. Plasmacytoid dendritic cells are the major type 1 interferon producers. They are antigen-presenting cells, but there are not that many of them in the peripheral blood. If you have 0.1%, that's a bit what we can expect. However, they are major type 1 interferon producers and critical for antiviral immunity. So we thought, why not then also anti-tumor immunity? Type 1 interferons are very beneficial also to get rid of tumors. So what we did was we have this vaccination strategy again. We have a patient, so stage 4 melanoma patients coming into the clinic. We isolate with a closed system the plasmacytoid dendritic cells. We culture them overnight with a survival factor, in this case IL-3. Then we load them with clinical grade peptides present on the tumor cells. So we here chose GP100 and tyrosinase that are peptides from the melanoma cancer cells. And we used a clinical grade TLR ligand. In this case, it was a vaccine against FSME, what was capable of inducing nice interferon alpha responses 6 hours after stimulation. And because it's a vaccine is injected into patients, it's clinical grade, so we can use it in our studies. So this results in a mature PDC product. So mature PDCs loaded with the peptides, and we injected them back into the patient. And we choose now, since there was so inefficient the intradermal injection, to do intranodal injections. And we do that 3 times every 14 days. So what was amazing was that we did not see a difference in the progression-free survival of these patients. So in blue are the plasmacytoid dendritic cell patients treated with plasmacytoid dendritic cells. In green are matched controls, similar type of cancer, similar age, similar in the amount of tumor cells they have. And then you can see there's not a huge benefit for the progression-free survival. However, when we looked at the overall survival, you can see that 50% of the patients survived 2 years, whereas our controls were doing really less, was not that many patients who did well. So we thought what was then crucial for these patients, because it seems that we are delaying the tumor outgrowth. First, we tested if the interferon we tried to induce, at least to get an type 1 interferon response also in the blood. And this was the case. So we injected the cells intranodally, but there was a sparking of the response into the blood. So you can clearly see after 4 hours already interferon alpha and also interferon beta, which resulted in a nice response. We did not see antigen-specific cells, so not against the tumor cells. So we hypothesized that we have these PDCs injected into a lymph node. They interact maybe with T cells, but that's not their main role. I think they produce type 1 interferons, and in this way they can activate NK cells and myeloid dendritic cells, which then can present antigen to the T cells. So I think it's the interferon alpha that activates cells of the innate immune system. It does lead to activation of local myeloid disease and the presentation of endogenous antigens. And maybe it's a better presentation if the tumor antigens are loaded onto the PDCs. So, and there might be a reactivation of dormant effector T cells. So the T cells that are there, but not stimulated well enough. So I think that interferon alpha produced by the PDCs locally in the lymph nodes is sparking an immune response much broader than only what they induce themselves. The second trial we embarked on was with the CDC2s. So this is another dendritic cell subset. And also this, we isolated the cells in a closed system. We again loaded them with peptides, as well as we matured them with GM-CSF. This gave intermediate activation status. We load them and then we inject them back into the patient. And again, we did every 14 days, 3 vaccinations, intranodal injection. What we observed was that we had some GP100 specific T cells, and GP100 specific T cells means that they are directed against the tumor cells in the melanocytes, the melanoma, and they were also producing interferon gamma. And this coincided with a mixed or response, a complete response, so the tumor disappeared already after the first cycle, but also after the third cycle. There was also people or patients with a mixed response. So this patient, for example, had GP100 specific T cells, had beneficial specific T cells because they produced interferon gamma, so they were able to really do their function. We had one tumor disappearing, but another tumor was coming up. So we really observed that in the brains, there was another tumor coming up. If we conclude on this trial, so that CDC2's complete overview, here we could observe that the progression-free survival was better if there was functional specific T cells compared to the patients also both treated with dendritic cell subset with the CDC2s. And also the overall survival, patients who were able to mount a functional T cell response did much better than patients who did not have this functional immune response. So in summary, we can tell you that clinical trials with PDCs and myeloid disease are feasible. You can produce these vaccines rapidly. It can be within 48 hours that you can produce them and possibly inject, but then you have to do all the quality measures before you can inject. We did not observe severe side effects nor any toxicity. And we also observed that even small numbers of plasmacytoid dendritics or myeloid disease can induce a response in cancer patients. Furthermore, if we could see antigen-specific multifunctional T cells, you could increase the overall survival in these patients. And the last point is that I think that the PDCs and the myeloid disease exploit different mechanisms and might have a synergistic effect. So you could combine them. We got the opportunity to do this in a large phase 3 trial. So we combined the PDCs with the myeloid disease. We had patients with melanoma, stage 3B or 3C. We randomized them 2-to-1. So 2 patients got the vaccine and 1 patient got the placebo in that range. That was due because the patients were more willing to collaborate or to participate in the trial once there was a higher chance of getting the vaccine. You can imagine that if you have to go so many times to the hospital and to undergo a leukapheresis also in the placebo group and all these intranodal injections that you want to have the vaccine and not the placebo. So that's why on the basis the patients wanted to have this 2-to-1 so that more patients could get the vaccine. We were able to accrue 150 patients and then adjuvant treatment with anti-PD-1 antibodies was standard of care. So then the placebo arm, in which we only gave them placebo injections was not ethical anymore, because there is another therapy with this anti-PD-1 antibodies, what's standard of care. So you cannot then compare it with nothing. So then we had to stop our accrual. Again, we used here two types of dendritic cell subsets, so both the CDC1s and the PDCs, and we load them with many more peptides, but also, and we matured them with protein mRNA, and we were able to inject them again into these patients. To first give you an overview of what the patient looked like, if you look at the patients treated with the NDC, so the natural DCs, that's how we call the blood DCs together, and the placebo, you can see there is not a huge differences in the age, around 55 years old, the median 54, and also the male-female was also nicely distributed, slightly more males than females in both categories. If we look further to the patient, the clinical patient's characteristics, also there we could observe that there was a nice bit more stage 3C melanoma patients in the placebo, but otherwise they were quite comparable. Then we first investigated adverse events, and like expected, we did not see a lot of severe toxicity. We had a bit in the NDC group, but also in the placebo. Flu-like symptoms are very, very logical and normal side effect, what we observe often. And most of the severe toxicity also due to the apheresis. And then we looked at the clinical outcome, and we observed that there was no difference between the patients treated with the NDCs and the patient who got placebo. Not in the recurrence-free survival, neither in the overall survival. So this was quite disappointing that we did not observe a difference in the clinical outcome. And then we wondered, did we not do well with inducing the T cells? So that was not the case, because here we observed already that we wanted, this is the stage 3 melanoma patients. We could observe 2/3 of the patients mounted a T cell response. And also here, it was completely the same numbers of T cells that were induced. So it was not that we did not induce the T cells. So concluding from this was that the production of the DC is feasible for a randomized phase 3 trial, and that was a multi-center trial, so we did it in 2 centers. We were able to give it. It's well tolerated, mostly mild grade 1-2 adverse events, but no clinical benefit was observed in stage 3 melanoma patients. And we could observe, like we hypothesized, that in about 70%, 67% of the stage 3 melanoma patients, we could observe tumor-specific T cell responses. So then, as a researcher, you think, wow, what's happening here? We see the T cells. Previously, we were able to see that the T cells were really beneficial for patients, so for their clinical outcome. So why did we not show clinical efficacy? We still don't know the answer. We do know that the induced T cells responses are there, but we do not know if there's a good quality and maybe not recognizing relevant tumor antigens on the tumor cells. Furthermore, maybe the tumor microenvironment prevents T cell mediated anti-tumor activity. We did observe that the microbiome composition can be unfavorable, and the group with the placebo had a more favorable microbiome composition than the group with getting the vaccine, although it was a completely double-blind study. And maybe the DC vaccine is corrupted by the tumor microenvironment. Or we gave the DC vaccines too late. Should we give it much earlier during the response, or before the cancer gets really a cancer? So we first thought maybe the DC vaccine is corrupted by the tumor microenvironment. Here we come to more basic science. So we have the prostaglandin E2, and we learned that this is produced in really high amounts by the tumor cells, and that it's a lipid mediator, and it modulates inflammation and immune responses. So what we observed was that cancer patient with a benign tumor, to have lower levels than patients of PGE2 than patients with a higher number. Also, healthy donors do not have that much PGE2 in their serum as the patients with melanoma. That's much increased. Furthermore, if we look at a data set and available on the internet, the data, you can really see that low PGE2 or high PGE2 really makes a difference in clinical survival. So systemic and local PGE levels lead to a poor survival. So maybe if we have PGE2 having in close proximity of our dendritic cells, that might induce a suppressive or dysfunctional state. So in disease, immunomodulation occurs via the eperosteroid receptors type 1 and 4. These are the only two expressed on dendritic cells. There are 4 of these receptors, but these two are expressed on dendritic cells. And what we observed was that blocking PG2-mediated DC function, so here we have the conventional, our DC2s, which we used in the second trial I showed you. If we have a maturation cocktail with PGE2, then you can really see that the DCs are upregulating the PDL1, and that can be inhibited via EP4. As well as you have the relative production of IL-10 production. If you add PGE2, there's a huge amount of IL-10 production, and that's not favorable for inducing tumor immune responses. You can block that with anti-EP4. So also on the plasmacytoid dendritic cells, we see that if we add PGE2, it's unfavorable, so you get less interferon alpha production. It can be restored if you block the receptor EP4. You can also get less CXCL9 production, which is MCL10 production, which are chemoattractants for T cells. So I think in the future, we might have to use these inhibitors together with our dendritic cell vaccine to get a better activation of the immune system. Another point is maybe we are too late with the dendritic cell vaccine. If the tumor microenvironment is so capable of suppressing immune responses, we might think about preventive vaccination. That might work much better than having it in a late-stage patient. So indicators of immunotherapy efficacy is, for example, if we look at patients treated with ipilimumab, anti-CTLA-4, the one that inhibits or prevents T cell inactivation, you get an active response, so you get an active T cell, it's restoration of the T cell proliferation and differentiation. And the effect of this therapy, this immune inhibiting therapy, is that the tumor mutational burden or the lymphocyte density, what is determining the effect? So what could these tumor infiltrating immune cells detect on human cells? So first, of course, the antigen, so self-antigens, to which tolerance is incomplete, because normally if we have antigens, our immune system is tolerized to prevent us from having autoimmunity. But there's always a kind of possibility that there are self-antigens recognized, like the GP100 peptide. It's expressed on melanocytes and on melanoma. And if we make a response against the GP100, the tumor cells disappear because they are also expressed on the tumor cells. But on the other hand, it can also be neoantigens, so epitopes that arises as a consequence of tumor-specific mutations. What we know now is that if we have the tumor mutational burden as a key indicator of immunoefficacy, because the lymphocyte density, like here on primary melanomas or on metastasis, did not determine the effect on immunotherapy, so if the patient had a benefit or no benefit. On the other hand, if you look at the tumor mutational burden and compare that or investigate whether immunotherapy is efficient, patients who benefit from this anti-CTLA-4 had a higher tumor mutational burden than the patient who did not have this effect. So also here, not only the primary tumor, this was the case, but also the metastasis, often taken years after the first primary tumor. So in the primary tumor, we can already see whether a patient can benefit or no benefit from immunotherapy. So tumors with a high tumor mutational burden are very good candidates for immunotherapy. And one of these tumors is in the Lynch syndrome. Individuals with Lynch syndrome have a germline mutation in the mismatch repair genes. So this increases the lifetime risk of different kinds of cancer. So in their DNA repair system, something went wrong, and therefore they have a lifetime risk of 30 to 70% of colorectal cancer, but also endometrial cancer and other cancers. And this is often diagnosed at a young age, so 40 to 45 years. And I thought it was not that common, but being now more introduced to it, it's about 1 in the 300, 370 people who have this Lynch syndrome. Many people do not know that they have it, but because it's not that known. But if there is cancer at a very young age in the family, people should get tested. So these patients have a defect, or actually they are still healthy individuals. They have a defect in DNA mismatch repair system. This leads to more DNA damage and mutations, so both insertions as well as deletions. And that gives rise to tumor-specific neoantigens. So if one of these DNA mutation leads to a tumor, they have neoantigens. It's a generation of the frameshift peptides. So this gives a very, very high tumor mutational burden. So Lynch syndrome, individuals with Lynch syndrome have a germline mutation in the mismatch repair genes, increased, especially this 30 to 70%. Now I go into the mechanism again. So you have here the mismatch in the DNA of a dividing cell. Here comes the mismatch repair system. In Lynch syndrome, this is not functioning very well. So what you get is that you get a frameshift mutation, and that is at specific spots. So it's not random. But if you, for example, have here 10 A's that has to be read, and it is one more or one less, you get a frameshift mutation. And especially at these spots with high number of repeats, you get earlier mutation than in other parts of the DNA. So this leads to a frameshift peptides and frameshift proteins, because after this you get a fully new protein. These proteins and peptides are going into the proteasome. They get degraded into peptides, and this leads to presentation on MHC class 1 that can be recognized by the specific CD8 T cells via the T cell receptor. So you get, in this way, tumor-specific neoantigens in these patients with Lynch. So detection of neoantigens by the immune system, if you have these mutated cells, the T cells, immature dendritic cells, take them up, they mature, and then will stimulate neoantigen-specific CD8 T cells. So we get again an army of memory T cells, and they will delete the mutated cells and leave the non-mutated cells where they are. So it's a very specific way of getting rid of mutated cells, even before they become a tumor. So we have tumor-specific mutated neoantigens. DNA damage is mutations. Tumor-specific neoantigens, neoantigen-specific T cells. The more DNA damage, the more neoantigens, the more T cells recognizing these neoantigens. And indeed, in patients with Lynch syndrome, even before tumors are detected, sometimes antigen-specific, these neoantigen-specific T cells are already indicated that they are there. So this is very important for the therapeutic efficacy of immunotherapies. It's identified these neoantigens as a major class of T cell rejection antigens following anti-PD-1 or anti-CTLA-4 therapy, so the immune checkpoint blocking therapies. And therefore, we might think that we can have preventive disease vaccination. Because on pre-cancer cells, so before the cell becomes really a cancer, the neoantigens are already expressed by the cells. And then if there are many of them and they become a tumor cells, then there are even more of these neoantigens expressed. So we want to prevent that precancer cells become cancer. For this, we have set up the preventive dendritic cell vaccination protocol. Now we do not have a patient, but a healthy individual, but we depict it as a patient to remember that we should say that it's still a healthy individual with a precancerous lesion. Although no cancer yet, so we don't know even if there is a precancerous lesion, we get immature dendritic cells. Again, we load them with tumor-specific antigens, and now we use these neoantigens from the patients that we know will exist. We mature them, and we inject them back. Here we do vaccination with neo-caspase-5. So this means that it's a neoantigen due to a frameshift mutation in caspase-5, neo-TGF-beta receptor 2. So here it's again a neoantigen derived from the TGF receptor 2 protein, but after a frameshift, and CEA. CEA is a tumor antigen for the colorectal cancer. And because these patients have a high risk of getting colorectal cancer, we also included this antigen. Also for ethical reasons, so that we knew that at least one antigen should do the job and prevent cancer, or at least it should be expressed on tumor cells in the colon. We started this study in 2008, so not a lot was known at that time about neoantigens. So what do we do? Preventive vaccination against cancer. You know it's already there for viral-induced tumors. Then the HPV vaccinations, for example, are given. And a prerequisite is that you need early malignant antigens are known so that you know which antigens will arise. Otherwise, you cannot vaccinate. Who do benefit the most? So we have here the patients with an intact potent immune system, so pediatric patients, patients with resected tumor, or these patients with no tumor at all, but prone to develop cancer. And that was our Lynch syndrome population. So that's why we included in our preventive DC vaccination Lynch syndrome patients. So it's a phase 1/2 clinical study. Started in 2008, or at least then we got the money. So we started a bit later. We first, of course, wanted to know, is it safe and feasible to do this? Now, what we observed was that the vaccine had no severe side effects in 22 of the 23 patients tested. We had no autoimmunity in any of the patients, even not if we were able to induce antigen-specific T cells, and we did 9 injections. So the primary objective was met. Of course, we perform a phase 1/2 clinical study. We also want to know the immunological outcome. So are T cells induced? Here you can see the first 3 patients we treated. These were the patients who had a cancer, but it was removed. This was a kind of safety cohort, or the first lead-in cohort. 3 patients who did have cancer, but afterwards were cured. And what we could observe, but there was nice responses, again here in the upper part, against caspase-5 in all 3 patients, but also in TGF-beta receptor 2. In 2 of them, we could observe a nice T cell response against these neoantigens, and also against CEA, the antigen we had for the colorectal cancer. So the secondary objective, induce or enhance an immune response, was also met. We then did also more patients, so the 20 patients who were really preventive, so that was in a preventive setting. And here is the overview of this slide. And it's a bit of a complicated slide because we also wanted to include the clinical response. And we thought it was important to link the T cell specific responses to TGF-beta and at caspase-5 to see if this is helpful for getting no cancer. So here on the left are all the patients, and also here are the patients. This is the caspase-5 outcome. So you can see that in 15 patients, we could induce caspase-5 neoantigen-specific T cells. And we were able to induce in 9 patients TGF-beta receptor neoantigen-specific T cells. what you can see furthermore is that these patients have either tumors or adenomas. So what we could see, these patients get every 2 years their colons checked, and they take out adenomas, carcinomas, everything they can find. So that's what they do as a preventive setting in a colonoscopy. Here you can see clearly that caspase-5 in red was present on 2 before. Mutation was present on 2 samples taken before, in 2 patients before, and in many more after. So this was quite disappointing, because you can still see here that although the patient had specific T cells, there were adenomas, so precancerous lesions, with the mutation. TGF-beta receptor 2, the mutation was expressed in many more patients before vaccination. But the good news was that in these 3 patients who had this TGF-beta neoantigen expression or neoepitope expression before, it was not visible anymore afterwards. So it was gone. So this could mean that we eliminate, by the immune response against TGF-beta receptor 2, that we eliminate the mutated form of TGF-beta receptor 2 expression, so that it's recognized by the T cells. Then we looked at the clinical responses. Here it was even more obvious. The caspase-5, so patients who had caspase-5 specific T cells present in orange and absent in gray, there's no difference for these patients in clinical outcome, so in times of no carcinomas. So it didn't matter if they had this response. However, the same patients mounting a response to TGF-beta receptor 2, here in green, the patients who did have the TGF-beta receptor 2 specific T cells, in red, the patients who did not have these specific T cells, you can see that they almost all survived the 10 years, and we are waiting for the follow-up of the other ones. So this is really remarkable. So the T cells recognizing TGF-beta receptor 2 were able to get rid of the mutations in the adenomas, and also the clinical response was much better in these patients. So how come these huge differences between caspase-5 and TGF-beta receptor 2? So what we did, we tested the T cells isolated from the patient for the recognition of tumor cells expressing the mutation. First, we have peptides loaded on tumor cells. We use this BLM, which is a melanoma cell line, but you just load them with antigen. And you can clearly see that if you add more T cells, you can see an induction of tumor cell killing. And if you load these peptides of caspase-5 on tumor cells, also here you can see that there is a nice increase of recognition of the tumor. So if you load the cells with the tumor peptides, they are recognized by the caspase-5 and the TGF-beta receptor specific T cells from the patient. However, the problem arose when we started to test tumor cells transfected with the whole protein and not loaded with the peptide. If we did that for the CEA, so the other antigen we used, we can clearly see if you add T cells, then there is a specific killing. So this is the unspecific killing, and this is the specific killing by T cells recognizing the CEA from the patients. However, if you do this for caspase-5, there is no difference. So caspase-5 specific T cells do not seem to recognize the full protein. Furthermore, if you look at the TGF-beta, here you can see that there is specific killing of TGF-beta receptor 2 mutated tumor cells expressing the mutant. They are recognized by the T cells. So this indicates that the TGF-beta receptor 2 T cells are able to recognize the mutation, and the caspase-5 is not able to recognize the mutation. And since we started this trial in 2008, we now checked with all the prediction programs how these are predicted for MHC class 1, for HLA-A 2.1. And then it finds out that caspase-5 is not presented on the tumor cells. So it's somewhere in the proteasome cut and it's not presented, and only the TGF-beta receptor 2. So now we end up with a nice control. So that is that if we have caspase-5 specific T cells and also the TGF-beta specific T cells, there is no usefulness of having these caspase-5. It's now our control. But since it's the same patients and the same cells, we can really compare these groups, and we can really show that having this specific immune response is beneficial for the clinical outcome. Of course, we would love to know why TGF-beta receptor 2 neoantigen-specific T cells are so efficient, because it responds to only one antigen mutation. It's only a 9-mer amino acid peptide and presented in MHC class 1. What we observed is that functional TGF-beta receptor 2 inhibits cell proliferation and induces apoptosis. So this means that a mutation in the TGF-beta receptor 2 may lead to uncontrolled cell proliferation and reduced apoptosis. So it's directly contributing to tumor development. So if we, with our vaccines, are eliminating these precancerous cells expressing the TGF, this mutated form of the TGF-beta receptor, that might prevent the uncontrolled proliferation. So it really aids cancer prevention. So identifying mutated TGF-beta receptor 1 as driver mutation in early cancer cells underscores its potential as a prime target for preventive vaccination in Lynch syndrome patients. And indeed, our results show that if we have preventively vaccinated Lynch syndrome patients who mount a T-cell response to the mutated form of TGF-beta receptor 2, but not to the caspase-5, because that was not recognized on the tumor cells, and they did not develop cancer for more than 8 to 10 years. So I come to my conclusions and my future perspective. I think that we can state that DC vaccination against frameshift-derived neopeptides is safe and can give rise to immune response in Lynch syndrome carriers, so individuals do not have cancer yet, without any signs of immunity. How to prove and enhance clinical efficacy, because I showed you that only 9 out of the 23 patients mounted an immune response to this TGF-beta, this neo-TGF-beta receptor 2 peptide. We think we should include additional neo-TGF-beta receptor 2 peptides presented in other HLA alleles, so that you get more alleles, more T cells involved. We should include additional frameshift-derived peptides, and preferably from other driver mutations, which should have a role in cancer progression. We think in a subsequent trial, we should include patients in their late 40s or starting from their late 40s. In this trial, we included patients from 26, but also from 75. It was the first trial, so we didn't know that we should have been a bit more strict on the age criteria. Normally, you say everybody between 18 and 75 can participate in the trial. But in this case, especially if patients are in their 40, 45, if you then start vaccinating, it might give you more hints about the clinical efficacy of the study. And we should make a decision on which DC type we can choose from monocyte derived, but also the DC subsets, or do a combination. I want to conclude with acknowledging all the people working with me on this project. We have a large department, medical biosciences, but before we had tumor immunology, which is now part of the medical biosciences. And all these people participated in the trial, either making the dendritic cell vaccine or doing a lot of the immunomonitoring, and especially also the identification of the specificity of the TGF-beta receptor 2 mutated versus the caspase-5. That was done by Asima Abidi, who recently defended her thesis. We did this together with the medical oncology, but also with the clinical genetics, and Nicoline Hogebrugge was one of the co-PIs on this study. Thank thank you very much for your attention.
Thank you very much, Yolanda. I'm sure we're going to have a lot of questions. I have some, and they are going to come on online. So you can either do it on via X. You can see it here now. Just find ask questions, and you will get an answer. And hopefully, it's going to be a very fruitful discussion there. I also want to announce next week's speaker, Mark Ragg, who is going to talk about engineering antibodies for immune stimulation. And I want to wish you all a good week until our next talk. So thank you very much, Yolanda, again.
Thank you. Have a nice day.
You too. Bye.